I'd been feeling just kind of funky for a couple of weeks, and I was getting full really quickly, but I was bloated mostly. So I was like, I need to go to the emergency room. Something was wrong. They took a CT scan, and my whole abdomen was a massive ovarian mass. I went to the emergency room at 8 o'clock on a Wednesday morning. Friday morning, I had a total hysterectomy.
She had a mass, a little smaller than a watermelon. We removed that. We did a total hysterectomy, so the mass with her ovary, as well as the uterus cervix, the other side fallopian tube and ovary, it did show cancer. So we removed lymph nodes in her pelvis and lower abdomen. We removed what's called her omentum, which is a non-vital structure, as well as took biopsies. And thankfully, all of the disease was confined to the pelvis. And then about a week later, we got her final result of the pathology.
I had ovarian clear cell adenocarcinoma. Ovarian clear cell is a very aggressive type of cancer.
It is a less common version of the typical ovarian cancer that you hear. Now, there's three main larger subgroups of them. There are epithelial types, which account for the majority of what we see. And then there are two rarer types called germ cell and sex-scored stromal tumors. Clear cell is a less common variant of that epithelial type, which is the typical ovarian cancer you hear of. We discussed what the recommendations were and why we recommended systemic chemotherapy, as well as other testing that we do on her and on the tumor to look for any genetic components. She recovered from surgery quite well, and I believe by week 4, she started doing systemic chemotherapy. With ovarian cancer, there's a relatively tried and true regimen. It consists of 2 medications. One is called carboplatin, the other is called paclitaxel. The entire treatment course can be anywhere from 3 to 6 cycles. Each cycle lasts about 3 weeks. So she was under treatment for about 4 months. She had CT scans at regular intervals that in the beginning we did quite frequently, and then as she was progressing and doing well, we spaced out a little bit further along. And then we have tumor markers, which are floating proteins in the blood that don't diagnose cancer, but they are something that we use if they go from normal to becoming elevated. That's a concern for a cancer recurrence. We also use them in our initial evaluation of ovarian cancer. For Holly, her CA-125s were not very high in the beginning, before we even did the operation. And then by the time surgery was over, I believe her CA-125 was under 10, which is negative. So CA-125, where it had a utility, it didn't necessarily give us the full picture.
The stuff that was out there, the blood test and the CT scans, that was all we had. And for me, it wasn't good enough. Wasn't doing what I needed it to do for my own peace of mind. And so I got the name of the Signatera company. So I did a ton of research and took it into Dr. Nizam. I'm like, hey, I want to do this test.
So the Signatera test looks at certain markers from the original tumor. So what they do initially is they will request a sample from the original pathology. And through that, they can give you a negative, they can give you a positive. The CA-125 wasn't going to give us as much information as we'd like, and she was getting CT scans regularly, but I don't want her to go through getting a scan every 3 months. If there was something that maybe we could do to space that out, and for her case specifically, that it gives us more information. So we thought that this was a good adjunct to her care. We told her it's not going to be the only thing we do by any means, but we do think it will be helpful in watching your cancer. And we know that if we're starting off negative, which thankfully she's been for the entire time that we've done this, knowing that it's negative is great. But if it changes from negative to positive, that's where we have to really investigate further on top of what we're already doing. Having it stay as negative is reassuring to me because we know that now we're looking at the trend. And if the trend is nothing, I'm optimistic. And especially if I have that with the normal CA-125, a normal CT scan, and she's asymptomatic and her exams are normal, then I can say with more confidence that she has no evidence of disease or NED like we talked about before. And I think for her and for any patient, that's what we want. We want to get as much information as possible to know that we are negative and that things are going as well as we hope for. So having the Signatera with our other modalities does fortify my decision-making. The majority of ovarian cancers, when they recur, typically recur within the first 2 to 3 years. So we're not going to watch her any less frequently. We're not going to say that we've won yet, but it does give us a lot more confidence that everything's going in the right direction. It is individualized for patients like Holly, or I have patients on immunotherapy for other cancers. I think that it is a very useful tool, and I think it gives us that much more information.
I'm using it for my surveillance. It's another tool to see if it comes back. I would get a ton of anxiety, they call it scanxiety, because I didn't know if they would find anything. But the Signatera test, it takes away that anxiety.
This helps give them the reassurance that things are great, I feel well, I don't have anything going on, and my test is negative. It also potentially may tell us when we need to be more aggressive in terms of looking for a recurrence.
This Signatera test gives me the power to just go on with my life instead of constantly what if.
Cancer care is complicated. There's no easy way around it. It's not easy for the patients. It has a lot of difficult things for them, their family, and everything. And I think being able to add an additional test that can give them positive or negative information, just more data and a better way to direct their care, is very good, and it's an area that we need more of.